Thank you, Bill, for that very kind introduction. Very appreciated. Dear colleagues, I have no disclosures. My task is to talk about standards for reporting outcomes of treating biliary injuries, a new way of doing this. There is no standard, or has been no standard way of reporting results of treatment of biliary injuries. And this obviously impairs progress because we can't compare results accurately. There are about 15 prior rating scales for reporting results, and their parameters include liver function tests, symptoms, interventions, cholangitis, survival, cost, and quality of life. Despite this, most scales have been created for a specific case series, and none has been adopted widely. Let me give you an example about a problem in liver function tests. Some scales prioritize normal liver function tests, but moderate liver function test elevations exceeding standard reference values are common after repair of biliary injuries in patients who have had excellent results. So to try to deal with this problem of accurate reporting and getting a system to accurately report results of biliary injuries, we put together a 19-person international multidisciplinary group with members from all continents and addressed this problem over 2 years. The new system has recently been published in HPB, our journal. Our purpose was to develop a standardized system for reporting results of treatment of biliary injuries that allows the following: comparison of outcomes of groups when the follow-up periods differ, which is almost always the case, comparison of surgical to non-surgical methods, and a system which accounts for the degree of severity of the injuries when making comparisons. On this slide, you see the names of the 19 people who contributed to this study. I'm not sure you can see all the names at the back of the room, so I'll show them again in a moment. If they came from Argentina, Australia, Italy, Mexico, the Netherlands, South Korea, Sweden, United Kingdom, and the United States, from all 3 areas of the IHPBA. And these are the last names of the people by specialty. Most of the people who worked on this were surgeons, but there were eminent biliary endoscopists and interventional radiologists as well. All communications were conducted online. Multiple iterations and proposals were considered over a 2-year period. The final draft was approved by the entire committee, and no participant resigned or was dropped from the committee during the development of the proposal. So everyone agreed. At the end of this talk, I hope you will learn about a new way of measuring outcome, which we call actuarial primary patency rate, and a new way of grading severity of biliary injuries. If we refer to this reporting system, please call it the International Multidisciplinary System for Reporting Outcomes of Biliary Injuries, or IMS-ROBI. For this new terminology, you have to learn 4 essential terms. They are patency, index treatment period, primary patency, and secondary patency. Let's start with patency. Patency is defined as an open, functional biliary tree without devices, interventions, or episodes of infection, obstruction, or fistula. The term functional is very important because the biliary tree can be mechanically open but act functionally obstructed and prone to cholangitis. So patency, again, is an open functional biliary tree without any of these problems. Index treatment period is the second term. The index treatment period is the time during which a definitive attempt is made to obtain patency in an injured biliary tree by surgical, endoscopic, or radiologic means. Surgical treatments differ from endoscopic or interventional radiologic procedures in that surgical repairs are usually accomplished in one procedure. The surgical procedure is followed by a recovery period. So the index treatment period for surgery will consist of the day of the operation and the recovery period. Non-surgical treatments often require more than one intervention, and these are commonly performed over several months, so that the index treatment period for non-surgical treatments will consist of a reasonable period of opportunity for these treatments to achieve patency. Recognizing that the treatments are fundamentally different in this manner, the index treatment period will be different for surgical and non-surgical treatments. The consensus agreed that surgery should consist of an index treatment period of 90 days from the time of operation, which of course is the time that we normally measure complications. Endoscopically, it was agreed that it would be 1 year, and also for interventional radiology. As recently, the endoscopic literature has agreed that if there's a stenosis after 1 year of treatment with stents in the biliary tree, that is less than an optimal result. That has been agreed to in endoscopic literature. The third term is primary patency. That is the state achieved when patency exists at the end of the index treatment period. So remember, patency is an open functional biliary tree without devices, interventions, or episodes of infection, obstruction, or fistula. So for primary patency to be achieved, patency must be present at the end of the index treatment period. Note, the occurrence of cholangitis, liver abscess, jaundice, bile collections, or external biliary fistulas within the index treatment period do not affect the attainment of primary patency, provided that the patient is free of these at the end of the index treatment period. But these events should be captured and reported as complications of procedures, along with other complications, by standard reporting means for complications. So now we're going to look at several timelines. Here is a timeline for achievement of primary patency Here is the timeline for achievement of primary patency after the repair of a bile duct injury. An injury occurs. After a certain period of time, treatment starts. There's the index treatment period, and then one reaches the end of the index treatment period. For primary patency to be achieved, patency must be present at this time point. If patency is not achieved by the end of the index treatment period, then primary patency can never be achieved. If patency is achieved after the index treatment period, then it is called secondary patency. Now here is the timeline for measurement of primary patency after repair of a bile duct injury. There's an injury, the start of treatment, the index treatment period, and the end of the index treatment period. If primary patency has been achieved, the clock on primary patency begins at this point. When is patency lost? This is like measurement of survival in a Kaplan-Meier curve for cancer. Patency is lost, primary patency is lost when patency is lost, or it's lost at last follow-up if patient still meets the definition of patency. It's like censored data on a Kaplan-Meier curve. So here is an actuarial primary patency curve from actual data. This is from data we published in the Journal of the American College of Surgeons. This was not published because we didn't have this methodology, but this is what a primary patency curve looks like. It comes from this paper that was published in 2015. That is, the data comes from this paper. A proposal for standardized tabular reporting of observational surgical studies illustrated on the study of primary repair of bile duct injuries. In this paper, we were trying to do something to improve our observational surgical studies, which make up 90% of the surgical literature. So we tried to illustrate it in a study on bile duct injuries. But what happened, we got to the point where we wanted to say what was the result of the repairs, and we had no good way to do it. So that's when we put together the group of people that did this particular study that I'm talking about today. So here's the actuarial primary patency curve in 121 patients over 10 years. You can see it looks like a Kaplan-Meier curve. It is a Kaplan-Meier curve, but it looks like a Kaplan-Meier curve for survival after cancer treatment. Instead of having percent survival on the y-axis, you have percent primary patency. You can see at the end of 10 years, it was 91.8%. As you can also see in the red circle, most of the interest occurred in the first year, and here's a blow-up of the first year. So you can see there's a very straight line at the beginning. These are the people who did not attain primary patency because they didn't have patency at the end of the 90-day period of observation that was the index treatment period. And there were 2 people here who fell off primary patency because they developed a problem, such as a bout of cholangitis needing a stent. These people did not attain patency at the end of the index treatment period, so they never can attain primary patency, and these period lost primary patency in the follow-up period. The last term is secondary patency. Secondary patency is present when patency is present after the index treatment period is finished. So on day 91, if the stent comes out, you can't get primary patency, but if you fulfill the conditions of patency, then you have achieved secondary patency. Or it can occur when patency is restored after primary patency has been lost. In terms of secondary patency, patency may be lost more than once, and secondary patency may be achieved more than once. For instance, if you have a patient who loses patency after the index treatment period and say they require a stent, the stent comes out, they have secondary patency, but again they get a bout of cholangitis or a stricture, and then they need a reconstruction of the biliary tree done surgically, that would be 2 cases of restoring secondary patency. And so these are the groups, either in the first place, the people that did not get primary patency or that lost primary patency, that are eligible for secondary patency. How secondary patency is achieved is very important in the assessment of results. One patient may get it simply by removal of a stent or treatment of an episode of cholangitis. Another may need 2 re-repairs or even a liver transplant. So that's very different, and we have to have a way of being able to compare them in an equal way and not bias. So to do that, we introduced grading of patency. So primary patency is grade A, and secondary patency has 3 possible levels, B to D, depending upon what problems occurred or what treatments were needed to restore patency or to attempt to restore it. And this, which you purposely cannot read, are all the conditions that need to be fulfilled for having patency grades of B, D, and C. And you can see that there's a table for surgical treatment and there's a table for non-surgical treatment. And when grading how secondary patency was achieved, one would look in these tables and see which conform to the particular patient that you were grading. Grades B to D take into account events such as infection or fistula, interventions like surgery or stenting, and how often they occurred or were needed. The more invasive and the longer the treatment, the lower is the grade. It also accounts for patients who never attain secondary patency. So for instance, under grade B, you can see the surgical table, a non-surgical table. You can see for grade B, a secondary patency for under grade B might be stenting for a short period of time. Under grade C, it might be having to repair the biliary tree for a second time. Under grade D, it would include cases like needing a major liver resection and a repair, a bile duct, a need for a liver transplant, or an additional repair. To make fair comparisons between methods of treatment of bile duct injuries, there also has to be some equivalence in the severity of injuries when comparing methods. And what we chose to use as a way of doing that is to grade it depending upon the kind of injury under the Washington University classification of biliary injuries. As I said, some of you may know this as the Strasberg classification, but we call it the Washington University classification. And here's what we came up with. So the severity is international severity grading of biliary injury, and we came up with this idea of basing it, like we have done with complications in general, on the intervention that's needed to deal with the problem. So grade 1 are lateral injuries to the biliary tree, the grade A in the Washington University classification, where you have a leaking cystic duct or a leak from the cystic plate, or a lateral injury to the biliary tree. These are almost always treated by stenting. The treatment's usually pretty straightforward. If it's found at the time of injury, it usually requires 1 or 2 stitches. Grade 2 are the B and C and the E1 to E3 injuries. And these require 1 duct anastomosis or stenting, usually for a prolonged period of time, but with 1 duct that has to be stented. And the highest grade, grade 3, requires more than 1 duct for anastomosis. Now just say a word about classification. You may say, well, look, an E1 injury is not as bad as an injury as an E3, and you're giving it the same grade. That's true, but when doing classifications, and I've done a few of them, when doing classifications, you have to choose between granularity and practicality. And if you make a classification with too many groups, then that classification can not only not be remembered, but probably the number of patients in a group is going to be too small, even with large case series. Grade 1 severity injuries will almost always be treated non-surgically, while grade 3 injuries will almost always be treated surgically. Therefore, surgical versus non-surgical treatment comparisons will almost always be in this grade 2 group. In addition to determining patency and severity, the standards are comprehensive in other ways. I'll just give you an example. For instance, there has to be rules for comparing surgical, endoscopic, and radiologic treatments that take into account other factors than severity and give guidance to those writing papers in this area. For instance, patients, these are some of the rules. Patients who are not candidates for surgery should not be included in studies comparing surgical to non-surgical techniques. That sounds simple, but if you look in case series, very often there are people who are too sick for having surgery, and they should not be in a comparison. The other is true also. Patients whose injury cannot be repaired by non-surgical techniques should not be included comparing surgical to non-surgical techniques. In other words, if the patient needs a right hepatectomy because they have a vascular biliary injury, there's no way you can compare that to, and they don't belong in the comparison. Patients who have stents placed only to facilitate a surgical repair should not be considered to be treated by non-surgical techniques in comparative studies. But the continued presence of stents for greater than 4 months after injury in a patient who is fit for surgery is an attempt at treatment by non-surgical means as opposed to preparation for surgery. Results must be evaluated by intention to treat so that patients who fail non-surgical treatment then undergo surgical repair will be evaluated in the non-surgical group, and patients who fail surgical treatment and then undergo non-surgical treatment will be evaluated in the surgical group. And there's more. So I won't go over all the rules because I don't think you'll remember them, but they're there for you to use when you do a comparison between surgical and non-surgical, and also when you write up case series. There are certainly limitations, and by the way, I'm coming to the end of this talk, and I've purposefully made this talk shorter than a half an hour because although this is a keynote address, I'd welcome questions because you may have some questions about this methodology. But this system is based on clinician perspectives. It's how we think about, and the patient and payer perspectives may vary from that of the clinical perspective. Quality of life and cost are important outcomes that have not been addressed in this reporting system. And obviously, it needs to be tested in practice and might require modifications as people begin to present their results. We hope you agree that the new international reporting system for treatment of bile duct injuries provides a logical and objective way, at least it's an attempt at it, of reporting outcomes of treatment of biliary injuries and will become the method for further studies. I'm going to finish by showing this amazing picture, this lovely picture of a mother elephant delivering a baby elephant, as you can see by this blue arrow. The period of gestation was 22 months in an elephant, but that was not as long as the period of gestation of this reporting system. So I just want to finish by thanking all the people that worked on this so hard and with their great thoughts and patience, and being able all to come together to 100% consensus, which is somewhat unusual. And I pay special thanks to two fellows, Dr. Jiaying Cho and Dr. Ismail Dominguez, who put a lot of the legwork into this study. Thank you very much.
That was a brilliant talk, Stephen. Thank you very much. We do have time for questions from the floor. While people are making their way to the microphone, let me ask the first one, if you don't mind. Have you started to use the system now to retrospectively classify patients, or are you doing this prospectively exclusively?
So I think we have, you would think we would have a registry for bile duct injuries in our institution, but we've just actually initiated it, and of course we'll do this, but we've already gone back to do our group. I know surgeons from the Netherlands have told me that they're going back. Of course, the Netherlands will be the first to do this. Are going back and doing their analysis, and the group in Mexico City is also doing it. These are already published results, but now we'll publish them in terms of a way we can compare them, just like we can compare cancer results from different countries and institutions. So I would encourage you all to present your results this way, because one paper will be able to be compared to another paper in a very reasonable way, and it will facilitate meta-analysis of our results because there will be less heterogeneity. It will mean that we're going to eliminate a lot of heterogeneity. And if you want to eliminate a lot of heterogeneity, read that paper in the Journal of the American College of Surgeons in 2015 about a standardized way of presenting everything, not just the outcomes, but how the patient presents, what their lab results were, et cetera. We need to eliminate heterogeneity in our observational trials. It's one of the biggest problems we have in surgery, in my opinion, and we really need to tackle it in a very good way.
Yes. Question here.
Kapoor from India. One comment and one observation. For the surgical management, you've mentioned 90 days as the index treatment period, but the recommendation from the Johns Hopkins Hospital group whenever stenting is required is long-term stenting, which they say should be at least 6 months and preferably 12 months. In Lucknow, in India also, we, in a difficult stricture repair, we tend to keep the stents over a long period of time. So my suggestion is that the index treatment period for surgery, whenever an anastomotic stent is used, should also be extended to at least 6 months. So that's the comment. The observation is your curve. Probably the group missed it, but way back in 2006, we had published our results of 300 biliary stricture repairs, where we had given a similar patent. We didn't call it patency curve, we called it anastomotic patency curve, which was the same as Kaplan-Meier curve. So I request that that should be acknowledged.
Okay, thank you for your comments. I think that leaving stents in long term is something that can be done. I think very few centers do that anymore, and I think this is coming up with the current clinical practice. And you may notice that two of the authors on this paper are from Johns Hopkins. As far as the other information is concerned, we actually adopted this from the methodology, although it's different, but it's stimulated by methodology that has been presented for AV shunts, surgically created AV shunts. And the term patency, as far as I know, in biliary injury has never been used before. Thank you.
Question here.
Yeah, hi, Bill Nealon from Northwell in New York. Stephen, another extraordinary contribution. Great always to hear your wisdom. I know this is only about reporting and not about dictating practice, but you explained that the deadline for endoscopic management is a year. Many of us as surgeons have seen patients that are could be either surgically or endoscopically managed, where we see stents and restents over a long period of time. Can you just give me your thoughts on should there be a number or an amount of time at which you might say, why don't we convert over to a surgical strategy?
Yes, you're right. It's not a question about reporting, but I think from my perspective, what one has to take into account is the patient that's before you. So if you have a patient that has comorbidities and that is elderly, I think we would all lean towards stenting. If we have a patient who is younger and very healthy, I think we would lean more towards surgery. So I think that question has to be answered, at least in my view, and on an individual patient basis. I think both treatments can work, and I understand the advantage for surgery, obviously being a surgeon. I lean that way. But we also have to remember that when we do something like this, we have to take into account everybody's opinion. When you have 19 people and you're trying to get 100% consensus, there has to be some movement on the part of each group towards the center in order to make the classification agreeable to everybody.
There was someone about to ask a question who is not any longer, so if anyone else has one, please come up. But one other question I wanted to ask, Steve, let's say, how do you handle a surgical repair that is patent at the end of the 90 days, but has a drain in place for a low volume biliary leak? That would fall into the category of a failure to achieve.
That's a failure. And you have to be very, very rigid about the rules, because people try to game the rules. They said, this doesn't apply to me. Oh, he's only having 3 cc's of bile a day. If it's a microliter of bile a day coming out of fistula, it's not primary patency. Okay. Is there a question over there? No.
One in the middle here.
Babika from Sudan. Thank you very much for this nice talk. You mentioned quite clearly about the primary patency and secondary patency. But as you mentioned also, this secondary patency can fail. Why don't you went on and name it a tertiary patency rather, if the secondary patency fail?
That we thought of that. That's not an unreasonable suggestion, and maybe it's something that we will take up, because this is not the final thing in this area. I mean, we almost certainly will have to make some modifications once people begin to produce papers and say, you know, this worked pretty well except for this. And it's very likely that we will require modifications. It just gets a little complicated. Tertiary, quaternary, penternary. So we just said this is a second instance of secondary patency.
Great. Any other questions? Well, thank you very much for a very nice talk and great session.